to list eight generic competencies. So I'll just go with my definition. It's medical informatics is an evolving field of science that actually encompasses information science, medical science, and computer science that deals with the acquisition, storage, retrieval, sharing, and optimal use of information in health and biomedicine. So the next question is, what are the components of medical informatics? So there are actually four main components that actually cover the different aspects of medical informatics come into play. However, under these four major components, there are sub-components or branches that further help handle the minor details. Bioinformatics is one, which is use of medical informatics methods to facilitate research in molecular biology. Then clinical informatics, that's what we commonly use in clinical practice, use of medical informatics method to aid management of patients using an interdisciplinary approach, including clinical and information sciences. There's the consumer health informatics. This is actually more in regard to the patient or the client. Use of medical informatics method to facilitate the study and development of paper or electronic systems that support public access to and use of health and lifestyle information. Then there's one that covers the public, which is the public health informatics. Use of these medical informatics methods to promote public health practice, research, and learning using an interdisciplinary approach, including public health science. So it can be microorganisms as molecular biology, could be clinical in our practice, could be for the consumer individually, could be for public health generally. So these are the other subdivisions that actually help bring to light the four major parts that we talked about: nursing informatics, health information network, clinical information system, medical software engineering, and the likes. We can always go through the slides. So the functions of medical informatics, that's the next question. Basically, it serves a lot of functions, both for the patient, the system as a whole, the population. There's improved patient care. Generally, it makes access to healthcare easier, optimizing healthcare delivery, centralizing information such as medical records, patient portal. Then there's also some level of accountability when there's a medical informatics. Things can be monitored generally. Then there's better collaboration and coordination among healthcare providers. You don't have to send people, for example, using electronic medical record as a typical example, to run to the lab to get results. You open the portal and usually they're posted there already. So the whole back and forth is actually easier. Then this actually aid development of new medical technologies. For example, with algorithms that have been formed from patterns that may have been created with using your medical software programs, you can actually create artificial intelligence and make things a little bit simpler. Then you can use the data that is analyzed to develop insights and drive innovation. So you can actually you can create predictive models that can actually help us create other things that might be easier. For example, formats or predictive models of certain infections and outcomes or disaster management, as it were. Then improve administrative functionality. I like using the electronic health records for this. For example, there are times when you get messages that, okay, certain people have not been seeing patients for a while, because it's easy to assess who is seeing patients, who is not seeing patients, who wastes time in getting certain things done. Then you can actually check lag times. For example, if a result was requested on Tuesday, you didn't get it till like 5 or 6, 8 days later on the system. Everything is date stamped. There's enhanced research. You can easily gather research. You can type, I mean, gastroenterology, you can type, oh, people that came with non-alcoholic fatty liver disease over the 2004, 2000 and something. As long as it's on there on the system, I can easily just extract all those and use for my study. They integrate electronic health records to existing system, aiming for minimal organizational disruption and improve delivery to health service. So there are certain drawbacks that medical informatics can have. One of them is data quality issues. Once something has been entered on the system, it's usually stamped and it's fixed that you cannot really take them out. For example, I accidentally entered the wrong result on the patient's portal. It's there. It cannot be changed. You could probably go and make some editing, and this can actually affect data that might be gotten. So this can affect the accuracy, completeness, consistency of data, which can make it a challenge. The world is changing. It might not be a common thing that happens in Nigeria, but you can actually have data hacking, cyber terrorism, where a system is probably hacked and medications and prescriptions are changed to create threats. Oxygen delivery levels are changed, and this can actually cause a threat, and people can actually, ransoms can be paid for things like this. The cost is actually quite difficult to implement because it's expensive for a start, but eventually, on the long run, it's usually easier or cheaper in the long run. User adoption, a lot of us now, particularly most of our senior colleagues, got trained before the digital age came to play. So integrating into this might be a little bit difficult. And then there's always this little bit of a lag, as it were, from the old system to the newer system when you want to adopt some inertia. Then legal and regulatory issues. Now, you're a doctor, you have access to these patients' details. The records person is not trained to, or not. The IT person is not trained to have this access, but eventually they will have this access without prior authorization or training. Then what's the medical dilemma in my own terms? It's a situation where clinical events create scenarios where one needs to decide between two options, which may or may not be acceptable. A typical example I like using is a sickle cell disease patient who is in crisis, who already has a history of addiction or currently being managed for addiction. Decision to give or not to give opioid analgesics in view of probably underlying renal disease. Whether or not to terminate a pregnancy for a 12-year-old who got pregnant following a rape and insist on a termination. These are dilemmas that might be uh, uh, examples I can give. This a clinical practice has gone beyond just a normal clinical medicine to list eight generic competencies. Clinical governance is a skill that one should have as a clinical practitioner. Clinical audit this is actually going to help you make changes in what you're doing. Medical informatics is a must because the world is changing, it's evolving. It's beyond just parlor and jaundice right now. Advocacy, policy making, conflict resolution, human resource management, and health resource management and teamwork. These are things that competencies that we must have in practice. I'll be very quick. I know I have just a few minutes left. I'll just talk about medical informatics. The science concerned with gathering, manipulating, storing, retrieving, and classifying recorded information is a spectrum. Like I mentioned, it involves information science, computer science, and clinical sciences. It goes from the molecular level to the population level, from the one microorganism to the whole world at large. But medical informatics is actually the umbrella term. This just now it's a rapidly evolving scientific field that deals with storage, retrieval, optimal use of biomedical information, and knowledge and problem solving. It's interdisciplinary field. Then medical informatics, like I mentioned, computer science, information science, and medical sciences. Then just extracting use of electronic medical records, use of medical informatics, electronic health records to store comprehensive patient data. There's actually you have access to data from the lab, data from the pharmacy, data from the clinical records all in one system. You don't have to go back and forth. Makes it easier for you to make clinical decisions. Then there's also the room of telemedicine where you can actually manage patients remotely. There's health information exchange where you can actually, rather than write some long thing, you can actually just send a file for a patient probably going to India, and they have access to all that has been done for the patient all through. I use India as an example because that's a common place that we send people to. The personal health record, it allows the patient keep track of their own health, basically. The medical imaging is actually one of the branches where you have access to X-ray, CT scan, data analytics and predictive modeling, healthcare administration, patient portals, medical research, just like I mentioned earlier. Why is it important? It improves health quality, better data access, faster data retrieval and storage, enhanced quality assurance, increase healthcare organization efficiency, helps with sharing medical data. Then one thing that usually comes in is differentiating EMR, that's electronic medical record from electronic health record. Simply put, electronic medical record is basically tied to one individual or one health service provider. For example, as a doctor, you have your portal where you make your diagnosis, your documentations, and all, but you don't really have access to the other aspects, like the radiology aspect, the lab aspects, and all. They have their own specific electronic medical records. But when you have all together in an accessible, you have all of them together, that is the electronic health record. So it's a digital version of paper chart for one provider only, that's EMR. Then digital record chart for overall health from the various health providers, that's EHR. So the EMR, from what I said, cannot be shared with another healthcare provider, while the EHR can be shared. Patient information does not move outside one healthcare setting for the EMR. Then the EHR allows medical information to move with patients to various healthcare settings. EMR is used for diagnosis and treatment only, while the EMR is designed to support medical decision making in various built-in tools. Challenges of using the electronic medical records, just like I mentioned earlier, you have data security, privacy concerns. Whoever who has access, what level of access should each person have? So what you could do is encryption. That way, when the doctor opens the portal, it is the doctor's access and all the other things that he needs. When the IT person opens the portal, you shouldn't have access to the patient's information. You should be focused on the IT aspect. Those are things that you could do. That also comes with access control, and you can also do like a regular audits. You can have downtime. This is actually the biggest problem when you're trying to set up an EMR system in any hospital. This is something that is going to be talked about. So what you could do is always have a redundancy system, as it were, where you have something like a backup plan or a fail-safe plan, so that if these things occur, there is a temporary measure that can be used. This fail-safe could be having a duplicate record for this patient that can be used temporarily. It could be having an alternative internet access. It could be having like a local access, that's the intranet, that can still give you access to a few things, or even having paper system available where when these documentations are made, they can be transferred eventually to the system where they come back up. And of course, another way to prevent this or manage this is regular maintenance. Cost of implementation, well, this is something that must be planned before you start. You could do it in a phasic way. You could start with just the medical part or the EMR before you transit to EHR. Just in conclusion, it plays a transformative role in modern healthcare. by integrating information technology, data management, and clinical practice. It bridges the gap between medical science and technology, enabling healthcare providers to deliver more efficient, effective, and personalized care through use of electronic health records, clinical decision support system, telemedicine, and digital tools. I will give special thanks to Dr. Ede, who actually had presented this much earlier. Thank you very much.
Thank you very, very much, Dr. Justice, for the very, very lucid and clear presentation. Okay, so the floor is open for contributions and comments, questions from the participants. So in the chat room, okay, no hands up yet. So in the chat box, Dr. Cassidy Ide says, thank you for the lucid presentation. Please, are there limitations to medical informatics? Does it always work? So I think you have already listed the limitations in the presentations.
Yes.
The drawbacks.
Yeah.
Okay, so well, or unless maybe you have something extra to add, because she said, does it always work?
Okay, thank you very much. Well, it doesn't always work. Just like I mentioned, you can actually have a lot of drawbacks. And one of the big drawbacks with regards to our environment is the shutdown or breakdown. And I'm sure all of us have experienced that, where you wake up in the morning, you want to document, there's no network or there's no lights, something as simple as that. No, it doesn't always work. But these are things that we must anticipate and create measures towards resolving. I like to use my center, for example. I'm not saying it's the ideal thing to do. When I come in and there's no light, they were able to create an alternative way where we can access it through our laptops. That way we provide our internet and it still works eventually. It's not open to everybody. When you request for it, you can get it. It's just one of the ways. Then the intranet system also is something that can work. And then alternative ways, that's the redundancy plans that I mentioned earlier, can also come in. I'm giving an example now for the electronic health record. I also talk about the fact that the other aspect of medical informatics. Just using this for my example.
Okay, thank you very much, Chief. Okay, so the other comments, what are the 8 generic competencies? I think maybe you can just put it on the page because you listed them.
Yes.
Then other comments are thanks from Dr. Geoffrey, Dr. Ako, Dr. Amodu, Dr. Mustafa Mohammed, Dr. Lawrence, Toby Amaka, Dr. Becky. So there's a lot of thanks in the chat. All right, so I would just like to add to the question on medical dilemma, because well, they said we should say it in our own words. So I wanted just to add extra. So usually it's can also be defined as when there's a conflict. So when medical treatment is faced with a conflict that has to do with moral choices or decisions, or when more than one ethical principle of value can be utilized in the situation. So for instance, most times, usually there are some scenarios where there may be a conflict between using autonomy and beneficence. For instance, sometimes in our setting, we have patients that have been diagnosed maybe with a cancer, and then the family come and say, oh, we don't want you to tell the patients. So I think that's also because we still have to respect cultural values as well in making medical decisions. So sometimes that can pose some medical or ethical dilemma. And then also, of course, the popular one where we have for maybe some religious concerns where a patient doesn't want to receive a treatment, or maybe a parent on behalf of children, it's still medical dilemma, even though there's various steps that can be utilized to address those issues. But medical dilemmas usually have to do with when there's some conflicts in administering treatment, and the conflict usually has to do with different ethical principles or values that are to be considered in carrying out the decision for the patients.
Thank you very much, Chief. Thank you very much.
All right, so there are no hands up, so I'll hand over to our teachers and facilitators.
Oh, thank you, Dr. Justice. As always, you did justice to the discussion. Thank you so much. I must appreciate those that, Dr. Temitope, thank you. Those that, I don't know if anybody commented, but thank you for the interaction. We want more interactions though, but thank you for the ones we saw this morning. So I don't know if any of our teachers have anything to add. Chief
Okay.
Teacher, go ahead.
Hello?
Go ahead, please.
Yeah, thank you, Dr. Christabel. Thank you, Dr. Justice, for the beautiful presentation. I just wanted to chip in on the dilemma part, okay? I think
Okay,
the definition you gave sounded actually very good. Usually, dilemmas, there are so many um, um, perspectives to it, okay? So usually, one could say there's a dilemma when you have more than one possible choice to make and you are confused at which is the best choice to take at that point in time, okay? So already that consists a dilemma. I remember one of the easiest ways to get our radiologist on call to come and do a procedure, maybe like a scan for my patient, is to claim diagnostic dilemma, which is also a form of medical dilemma, okay? So I have like 2 or 3 or 4 different possible diagnoses that I feel that the ultrasound scan may be able to help me to resolve. So I just tell them that I have a diagnostic dilemma and they will come. So there are so many aspects to it. So I just wanted to bring that in. Of course, what Dr. Timitope said is also correct. Okay, so but the simplest way to look at it is that you have different possible choices to make and you're confused at which is the right right choice to take. That's a dilemma. Okay. So I hope I've been able to throw more light on that. Thank you.
Thank you very much, sir. Yes, you have, sir.
Thank you, Chief. So there's a question in the chat regarding this medical dilemma that should physicians accept gifts from patients? Can that be a dilemma?
Okay, actually, when I was researching this question, sincerely, that was one of the first things I saw. That was one of the first things I saw as examples of medical dilemma. Should physicians accept gift from patients? Should you follow them on social media? It was actually a lot of discussion I saw there. And in my opinion, yes, I think it can be a dilemma.
So, but what's the answer? Should physicians accept that?
Okay, sir. I think officially, sir, we should not.
Okay. Well, a gift and a bribe are like 2 different things, right?
Yes, sir.
Okay, let's look at it like this. For example, there's a particular patient that we managed in my hospital, and when he got better, some weeks later, he came to the clinic and brought maybe like crates of eggs or something, and gave it to the nurses that it's for all of us. Now, the patient had gone, and then we now started seeing maybe like 1 crate of egg and all that. And like, what happened though? They say, oh, it's 1 patient like that. The patient has gone. No, they say we should give all of you. Okay, so something like that. Should we refuse? And if we accept, is it wrong? Thank you.
Wow. Okay, sir. I think I don't have an answer, sir. What I would just say is that this constitutes a dilemma. It will now depend on the circumstance in which this gift is coming. Some of these gifts might come with the intention or hoping that they will get some special treatment or special support, in which case it should not be done. But in the scenario that you have painted, sir, I don't think it would be right to decline or send it back. That's my honest view, sir. If I were facing an exam, that's likely how I would want to address it.
Okay, so yeah, they constitute medical dilemmas really, because there's a thin line between bribery and just gifts. Okay, some patients actually give it without anything in mind; they're just being appreciative, while some give it with the mindset that, oh, this could color maybe your attitude towards them, make you attend to them more or be more partial to them. Therein lies the problem. Okay. So, and many a times, because it's difficult to discern which one, legally, we are not supposed to accept, actually. I think it's wrong for us to accept gifts from patients or the gay. No, accept bribes. I hope, Dr. Shitu, you are here. You are the expert in this kind of things. Please comment. Thank you.
My hand was up now. Nobody called me.
Oh, sorry. Please talk.
I didn't see your hand, sir. Sorry. Love it.
No,
Please
no
go
problem.
ahead, sir.
Okay. All right. I think generally we're talking about medical dilemmas. Basically, medical dilemmas are things that, you know, situations where doing the right thing and perhaps offending others, or you skating between the lines of being ethical in your practice, are the things that bring about medical dilemmas. Okay. Also, things that bring about legal issues can point towards dilemma. Okay, now in the case of gift collection, well, it is clearly stated that you should not receive personal gifts from patients. Okay. But like I said, there are buts. Now, if somebody gives you a gift that will benefit other patients, then that is fine. For instance, a patient you manage on the ward comes and says, oh, I want to put a television in your reception. It's not in your house. It's going to be used by other patients. So it's fine to receive those gifts. So those type of gifts don't have, there's no problem on receiving gifts like that. Or, oh, let me help you expand the ward. That they come and they build it themselves. You do not collect money for personal anything. Okay, it was for the betterment of other patients. So those type of gifts can be received. Okay, so there are no issues. Now, when it comes to personal gifts, okay, the law says we shouldn't collect, but there are some types of gifts that do not have value per se. For instance, let's assume you treated someone and his 12-year-old son makes you a card and says, oh, to the best doctor in the world. That kind of gift, right, you can receive because you really cannot put a value on it. Okay, so those type of gifts can be collected. Now, we also have to talk about it in the context of our cultural environment, that is. Okay, this is Africa, particularly Nigeria. Okay, there are some kind of gifts that, well, if you do not collect it, it may look quite offensive to the person that is giving you the gift. Okay. Also, when receiving such little gifts per se, I'll call them little, gifts that you cannot put a value on per se, then you have to do it and being sure that you do not break the ethical principle of justice. Okay, for instance, somebody is coming to your clinic for a chronic disease and it's on follow-up. And along the line, maybe you're a Muslim and you're fasting during Ramadan and it brings you a couple of oranges. That is a gift that is small, but if you don't collect it, it may look offensive. Okay, fine, you can take that kind of gift. But that kind of gift does not mean that the next time the person comes to the clinic, you give the person any special treatment. Okay, so you must be able to still maintain your ethical principles when receiving such small gifts that may offend the patient if you don't collect it. But in all, I tell everyone that, look, once the gift feels uncomfortable, then it means you can't collect it. Okay, once it feels uncomfortable, you can't collect it. All right, that is why things like a card or somebody's grandmother decides to knit you a sweater. Okay, those kind of gifts are more emotional than physical in value per se. So you can receive those kind of gifts, but generally receiving gifts is wrong unless it is for the betterment of other patients. All right, I hope this is a bit clear.
Thank you very much, sir.
Oh,
Thank you
thank
very
you,
much.
Chief. Thank you, sir. I think we've done justice to this question. So, Dr. Justice, we say thank you. Thank you. Dr. Timmy Tokwe, we can move to the next presenter.
Okay, thank you, Ma. So thank you, Dr. Justice. Dr. Maduka,
Yes.
you can start sharing.
Okay.
Okay, so you have 10 minutes. Thank you.
All right. Thank you very much. Can I be heard?
Yes.
Yeah. Good morning, my teachers and respected senior colleagues and colleagues. I'll be taking practice question 6, and the questions go this way. List 4 principles of ethical. List 4 principles of ethical principles and explain them. 2. A 69-year-old man who had a terminal cancer. His brother does not want you to tell him the diagnosis because he thinks it will worsen his condition. What ethical principles will you apply and why? The third question is, how will you handle this situation? So the ethical principles.
Was not reachable at all.
Hello, can I be heard, please?
Yes, you can be heard, but someone's mic. Okay.
Okay, so I can go ahead. So the 4 principles are respect for autonomy, beneficence, non-maleficence, and justice. So respect for autonomy simply means respecting a patient's decision or wish about their own body or health. So that is essentially what respect for autonomy means. And this respect can be shown through having to take consent from a patient for something as little as taking blood from the patient or citing an IV line. There's also the consent of assent, where consent is obtained, okay, for a minor through the patient's parent. So that one is an assent that is taken. So there are some minors also that have been able to attain certain responsibilities, usually because of cultural or religious backgrounds. So that kind of consent that is obtained from that person, okay, because of this cultural or religious background, that person is said to be an emancipated minor. And so also we can also sometimes go ahead to do something for a patient, in our mind, thinking that yes, that the patient will agree towards it. So that's an assumed consent. So that's for respect for autonomy. So beneficence has to do with promoting the patient's best interest. Okay, when we have choices to make, we make sure that the choices we make are choices that will benefit the patient. So that's basically what beneficence is. And in this, there is also a principle of paternalism, in which the doctor, treats the patient as though he's a parent to the patient. So trying to take decisions, okay, for the patient that are beneficial, okay, to the patient, even sometimes without the patient knowing about it. So that's the principle. That's where paternalism comes in. Now, there are also some decisions that we can take, okay, that will have a double effect. Okay, so we take a decision that could, at the onset, be beneficial to a patient, but in the long run may turn out to be harmful, sort of, to the patient. For instance, a patient that is in end stage of a malignancy or a cancer, the patient is in very severe pain, okay, and then we want to relieve that pain using an opioid, okay, but yes, the opioid could relieve that pain, but we'll also have in mind that this opioid could cause some form of respiratory depression, okay, with time. So that's where we talk about the double effect. So non-maleficence has to do with doing no harm to the patient. So it's somewhat similar, okay, to beneficence, but we just have to ensure that, okay, whatever decisions we take for a patient, of course, there are sometimes we find out that this decision may harm this patient expressly. So we have to avoid it. So justice has to do with distributing medical benefits, okay, and sometimes medical disadvantages fairly, okay, across everyone that is involved. So it's just to ensure that, yes, whoever we meet or whoever we take care of, we are just towards the patient. So that is basically the ethical principles. So for this 69-year-old man who had a terminal cancer, his brother does not want you to tell him the diagnosis because he thinks it will worsen his condition. So what ethical principles will you apply and why? Now, looking at this question, I want to apply the autonomy, respect for autonomy for this patient. There will be also a need for beneficence for this patient and justice. Now, this patient is a 69-year-old man. Yes, although he's terminally ill, but there is no place we are told that he has any form of cognitive impairment. So this patient is able to take decisions concerning his health. Okay, so we should respect the patient's autonomy. So the patient has the right to know, okay, about his ill health. So something like, okay, sir, we have been able to find out what is wrong with you. I'm afraid we do not have so much good news for you, but will you want to know about this? So the patient will now decide whether he wants to know. So by that, if the patient says he doesn't want to know, then we can respect that. So with this, we've respected the patient's autonomy as it concerns his health condition. Now, most times the patients will want to know about their ill health. And then sometimes they want to know the full extent of what they are into. So we can now go ahead to describe to the patient what, what they have, okay, how it came about, and possibly the various modalities of care, both the best cares, where the patient can get the best care and all that the patient can get. And this patient, being cognitively sound enough, will be able to make informed decision about what he wants and the choices he wants. So with that, we've been able to do right by this patient. We've been able to act on this principle of beneficence for the patient. So the beneficence emphasizes the principles which may allow him to receive appropriate emotional and psychological support and be able to have meaningful decisions about his health. So that is also where that principle comes in. Also, we can also buttress this point by the time we've done all these I've talked about, okay, being an adult, being somebody that is cognitively sound, okay, we've listed all the options, what is happening to him, all the options for him to choose. He's able to take the best decisions about his health. By so doing, we have extended a form of justice, okay, to this patient. So we've not denied him that right, okay, to know and to make his choices. So for this patient, we apply these principles, the respect for autonomy, beneficence, and also for justice. So how will I handle this situation of a relative coming to influence my not telling this patient about his ill health? Basically, this can be done through dialogue, okay? Dialogue. So I'll have to explain my role as a physician and the right for the patient to know. So for this patient, the relative, I will have to tell the relative that, see, this man has the right to know what is wrong with him. And so he has the right to know what all the facets of his problems and the care, most especially the care he can be able to get, the best form of care he can be able to get. Okay, and then because he is sound, he's not confused, he's not demented, he'll be able to make informed choices about how he wants his life to go from here, having in mind that this is a terminal illness. Okay, and so if we can also go ahead to tell, okay, the relative that if this man is denied this opportunity, okay, to find out, and he gets to find out in any other form, okay, he can take through the legal routes for everyone that is involved in denying him the knowledge of or the right to know what is wrong with him. So this is a way we can also try to convince the relative. And so if this patient is also made to be aware of all these problems, okay, he will be able to make certain decisions concerning his life. He's terminally ill, so he can be able to get a lasting power of attorney, okay, so that in case he's unable to make certain decisions, he can appoint somebody who necessarily will not be a relative, okay, to make those decisions on his behalf. He can take an advanced directive. Okay, he may begin to make his will or give us instructions as to a possibility of do not resuscitate in case of any eventuality. So, however, after explaining to this relative, okay, the only way, like I said earlier, that we may agree with this relative is if this patient does not have cognitive, is not sound, you know, by way of his cognitive abilities. So that's the only way. And okay, so by that way, we'll be able to ask for a lasting power of attorney. So if the patient, if there's a lasting power of attorney in this patient, so we will now act based on who has that lasting power of attorney. But there is also a clause to it. The doctor can also choose not to obey the person that has the lasting power of attorney when he feels that the decisions this person is taking for the patient, okay, is not beneficial. So we may go ahead to get go to a court of protection for the patient. So that is basically how we can go about this. So I just added this to the slide. If we want to, these are ways to assess whether a patient has, okay, the cognitive ability to make decisions for himself. So basically by discussing with this patient, that's why when we are doing ethics session or, okay, we try to tell them to recap what has been told to them, okay? And then by so doing, we can know whether this patient has the ability, okay, to understand what he's been told. Okay, and then to assess if the patient has the ability to retain the information. And then we want to weigh if the patient knows the advantage and disadvantage of the information or decision he wants to take. So for instance, this patient has chronic liver disease or cirrhotic liver disease and decides to continue to take alcohol. So we want to know, do you know what comes out from you continue to take this alcohol or whatever choices he wants to make? And then want to ask the patient again to communicate the decision he has made. So when we go through these steps, we're able to know whether a patient has cognitive ability. So I want to just quickly rush through these. Ethics is a major branch of philosophy which encompasses right, conduct, and good living. It is significantly broader than the common concept of analyzing right and wrong. So bioethics is the ethics of biological science and medicine. It's a means by which men decide between wrong and right. Some of the means that have been used previously include science, intuition, law, ethical guidelines, and superior decisions. So the importance of ethics is a reflection of respect for those who take part in research. It ensures no unreasonable, unsafe, and thoughtless demands are made by researchers. It ensures sufficient knowledge is shared by all concerned. It exposes a common standard in all the above respects. So there are historical views or historical abuses that have happened when it concerns to human and health. Some happened during the Second World War. There's also the Nuremberg War crimes where the Nuremberg Code was also drafted. There is also the experiments on Jews by the Nazi soldiers or Nazi doctors, which some of the examples are the 1932 Tuskegee syphilis study, there's the thalidomide study, and there is also the 1996 Pfizer Trovan clinical trial that took place in Kano State. So the basic principles of bioethics, which we've talked about, the respect for autonomy. We want to ask, does my action impinge on any individual's personal autonomy? Do all relevant parties consent to my actions? Do I acknowledge the respect that others may choose differently? So beneficence. So we want to know who benefits from my actions and in what way. How do I maximize these benefits? And one of the ways, or some of the ways to maximize the benefits, include to prioritize patients' welfare and to maximize the benefits as much as we can. And also, how will I act on the results of these patients? So having these questions in mind will also help us know how to fulfill this principle of beneficence towards a patient. So the principle of non-maleficence, which is to ensure that no harm is done to a patient. So some of the questions we may want to ask include: which parties may benefit, may be harmed by my actions? What steps can I take to minimize this harm? In the event of a disaster, how can I avert possible harm caused? So for justice, which, like I said earlier, is ensuring equitable distribution, okay, of benefits and risks among patients. So have I identified all vulnerable groups that may be affected by my actions? How do I ensure distribution of burden and benefits? Is my proposed action equitable? How can I make it more equitable? So we want to look at allocation of risks, allocation of benefits, and allocation of resources. So these are the four principles. Thank you very much for listening. I want to appreciate Dr. Ajibola Sanda, whose slides I modified a little bit to make this presentation. Thank you very much. I welcome questions and contributions.
Thank you very much, Dr. Maduka. Thank you for the very detailed and lucid discussion on ethics. I think this is actually related to a medical dilemma that we have been talking about. Okay, so there are no hands up yet, but there are some comments in the chat. So Dr. Ide Fioma, thank you. When do you apply assumed consent? Is this still autonomy?
Okay. Well, as assumed consent, okay. It was where I saw it. It was it was placed under assumed. It was placed under autonomy, but here it has to do with taking a decision for autonomy. Actually means respecting a patient's decision. So a patient has to take the decision. But sometimes a patient may be incapacitated. Okay, there are some situations where a patient is incapacitated, probably unconscious, and nobody around actually to take a decision for a patient. Okay, so in that case, sometimes we may want to take a decision that we think this patient would have taken had it been conscious or had it been in a position to take that decision. So I know we'll have cases where there are patients that are abandoned. Maybe they just come to the hospital, bring the patient to the hospital, and then the patient is left there, and nobody knows how the patient came, who brought the patient, and all that. Okay, so that's where that assumed consent comes in.
Okay, thank you, Chief. So Dr. Cassidy says, thank you. Then Dr. Ide Fioma asks that, can the doctor really go against the decision made by the relative with the medical power of attorney, irrespective of the outcome of the decision?
Okay, now, if I may go ahead with that question, you're talking about a patient that does not have the ability to make decisions for himself, right? And then someone has the lasting power of attorney. And then the person is taking certain decisions for the patient. Yes, the doctor can. But how this thing can come about is that, for instance, somebody has a lasting power of attorney as it concerns a patient, okay? But you know that the decisions this person is taking the person is not taking right decisions for this patient, as it were. The patient has a chance to life and all that, and somebody is maybe giving certain instructions that will make the patient not recover or something. Yes, the doctor can go against the patient or the relatives, the person that has the lasting power of attorney. You can go against the person's decision. But to do that, you have to now go to the court of protection, okay, to seek that power to go against the person that has the lasting power of attorney. Okay, and so when you get that authority from the court of protection, you now prescribe the best medical practice for these patients. So yes, the doctor can go against the will of somebody that has the lasting power of attorney, especially when the doctor feels that the decisions, okay, the person is taking is not towards the benefit of the patient. So yes, doctor can, but there are procedures to go about it. Thank you.
All right, thank you, Maduka. Dr. Becky Obasi, you have the floor.
Good morning, everyone. Good morning, Atishas. Thank you very much, Dr. Maduka. So this question is a good example of the dilemma that was earlier discussed, and bringing it to real life practice. Why? So I think there is a conflict between employing autonomy and beneficence to this patient, because in real life practice, we may have one or two relatives whom delivery bad news to may actually cause worsening of their health condition. I actually had a patient, a female patient whose husband died from retroviral disease, and the daughter, who is close to me, disclosed that the patient would actually do better if the knowledge of the retroviral disease is kept unknown to her. And initially, this was also discussed among the consultant. Initially, we told the patient that this is the situation, and the patient came very badly with encephalopathy. And subsequently, so we left the decision with the daughter, and the daughter was the one giving the medication, and the patient did not return back to the hospital. So I feel that between autonomy and beneficence, I think beneficence should be taken with more priority. So if this would improve the patient clinical situation, I think I would go with that principle other than autonomy, because if for this case scenario, after explaining the situation to the relative and you go ahead to inform the patient, and suddenly the patient develops a heart attack, I think that would also be a medical legal issue. So I don't know. I think I'm putting it forward for more discussion from our chiefs. Thank you.
Yeah, thank you very
much. Okay. Okay, I want to add my own question so that Dr. Maduka and then our facilitators can weigh in. So part of autonomy has to do with confidentiality too, like you explained in terms. So I'm quite concerned. I mean, the scenario painted, unless maybe there are some other things. So why is the relative actually being the one that has the information first, and then making this request in the normal chain of our patient's management, except maybe there are other things, maybe the patient was unconscious, and it just spiked my curiosity. I mean, the whole scenario painted. So Chief Shitu, sir, you have the floor.
All right, thank you. Yes, I like what the last speaker said. Very important thing. One, how did the relative know about this issue when it is obvious that the guy can actually, take decisions for himself? So why was autonomy shifted to the person's proxy? It should have been left with him in the first place. But we're not here to argue the whether the question is well put together or otherwise. But the most important thing here for us to point out is that there is no ethical principle that supersedes another. They should all be taken in the context of the scenario in front of you. Okay? Meaning that if more than one ethical principle is required for you to sort out that particular scenario, then you should sort out all those ethical principles one by one. Here, particularly, is the problem of autonomy. Now, as long as a person's mental faculties and the patient is able to understand information and react to information, then that person still holds his autonomy unless he legally decides to let it go knowingly. This type, he says he wrote a legal document that, look, I don't want to take decisions for myself. Let my son do it or something, then fine. So you cannot withhold information from your patient. Now, we should all know that the person that you are answerable to as a doctor is your client, which is the patient. You're not answerable to any relative or anybody that carried him or whoever is paying the bills. Nope. You are primarily responsible to the patient that you have admitted and you are managing. Okay, and thus you do your best to sort out things according to those lines. Okay. A principle that we should have brought in as well is confidentiality. Okay, this is confidential information. So, and information can only be told to others when you've been instructed to by the person who owns the information. So we should not mess around with that. Then the scenario painted by, I think, the second to the last speaker, by the patient that had retroviral disease. Well, so many things are going wrong here. One, before you test the patient must be aware of the test, and there must be pre-test counseling, and then a post-test counseling, then the results, and all of that. Well, if the person was unconscious at the time when you decided to run the test, and there is somebody taking decisions for the patient, then yes, the person should be brought up to the speed, counseled, and all of that. But as soon as the person is able to understand and function with information, meaning cognitively around, then that person should be told about what is going on. You do not withhold information from your client unless the client says, I do not want to know, then that's fine. Now, the only two scenarios where you break autonomy are: one, the person cannot handle it, meaning the person does not have the mental faculties to understand, comprehend, and react appropriately to information given to him. And the second one is when there is the issue of possible harm to the patient's self or to others. For instance, a patient decides to take a decision or that will potentially cause harm to him. Okay, now please note, it's not in the guise of if a patient decides not to get treatment, that's different. But if the patient says, for instance, give me a drug, I want to die, obviously it's causing harm to himself. Okay, and of course, legally in Nigeria, that euthanasia is not allowed. Okay, but if the person is taking, decides, oh, I don't want treatment, I want to just go and sit at home with my family, the person can take that decision because the person is not adding an additional harm to himself. He is only following the cause of his illness, which of course he did not cause for himself. Okay, so that is allowed. Now, if the person has harm to others, for instance, the Liberian that came into Nigeria with Ebola and had to be quarantined, I'm sure he wanted to leave, but he couldn't leave. He lost his autonomy. Why? Because it was going to be a problem to the society. Okay, and could end up spreading it to so many people. So other people were at harm. Okay, also if it's one person at harm, for instance, somebody has retroviral disease and he doesn't want to tell his spouse or he wants to keep it quiet and only to himself, In situations like that, you have to warn the person that, look, another person is at harm. Give the person the opportunity to tell the person by his or herself, or help create an environment so that information can be told. Or if the person decides, oh no, I don't want to tell the person, you have to keep compelling the person to tell the person. And if the person still refuses, then you may have to take legal channels to ensure you save the other person that is at risk or at possible harm from getting the virus from him. So those are the only issues when you want to break autonomy to an extent. All right. I hope I've been able to sort some of the issues out. Thank you.
Yes, thank you very much, sir.
Thank you very much, sir. There's a comment from Dr. Musa that says, thank you for the excellent presentation. Consent is for those above 18 years and those less than 7 years, while assent is for those between 7 and 18 years. So
On the
I'm not
issue
sure,
of
sir.
assent, hello, on the issue of assent, please, assent and consent are not quite the same thing, because consent means that you are actually giving the person the go ahead to do a particular thing. Okay. And of course, anybody below the 18 cannot give consent. Okay. At least in our own environment, that's it. Unless the person is emancipated, either by the person becoming a parent or the person getting legal means to free himself from his legal guardians, so to speak. But once a person is above 18, then yes, the person can obtain consent. Now, assent basically is just the person cooperating with you. So they bring a 10-year-old child to the hospital. The doctor say, I want to give him injection. The parents say, okay, go ahead. You've collected consent. Assent now is getting the person to cooperate. Now, look, I want to do this to you. I need your hand. I need to do this. You know, you're not taking permission per se, but you want the person's cooperation. So you have to get assent, so to speak. So the person, you know, cooperates, brings their hand. It even works the same way with somebody that may not be mentally here, okay, and somebody else is taking decisions for him, and you know, you want to do a procedure of which the proxy had said you can go ahead, but you still have to get the person into the idea of getting that particular thing done. That is what the assent is. Okay, so assent is not a legal document per se. It's just the patient, to an extent, agreeing to cooperate with you, so you can do what you want to do. Thank you.
Okay, thank you very much, sir. Dr. Ladimeji, sir, you have the floor.
Can I go ahead?
Yes, sir.
Okay, so I just wanted to make a comment regarding one of our colleagues that asked about using other forms of ethical principles to override autonomy, beneficence, or to override autonomy. You were saying that if you go and inform or explain the diagnosis to the patient, what if the patient now has heart attack because you told him the diagnosis and the relatives don't want you to do that? So the question is, number one important thing is that please, you must act professionally. Professionally in the aspect that you cannot make a comment like that, even in the exam, that what if the patient will have heart attack because you told him? That is not the cause of heart attack. You understand? So do not use emotions, emotional scenarios to define reality. You said, what if you tell the patient and something that happens and the relatives now sues us? That is, you're using emotions to determine reality. You cannot be afraid of being sued as a doctor. But what you should be afraid of as a doctor is you doing the right thing, so that when you are in the court of law, it will be clear to the judges that this is the appropriate critical steps the doctor has taken. It is more difficult for you to win a legal battle if the patient directly himself sues you because you withheld information from him or her that is beneficial to his health. because of the request of the family. That is more a dangerous thing to a doctor than you explain the conditions to the patient, you kept his confidentiality, and you got his autonomy. Everything, patient was well carried along in all treatment process than being blindfolded because of the request of the family. That is a dangerous thing in the court of law. So please, we need to make you understand that principle very well, not because of exam, but because of reality. It will be difficult to explain to a judge that because the wife said or the daughter said we should not let him know, and the patient now sues. The judge will ask you, please, who are you treating? The daughter, the family, or you are treating the patient? It will be difficult to defend. That can cost the certificate or the career of the doctor. So please don't be afraid of being sued, but be afraid of being wrong at the court of law. Anybody can sue for any reason. Even the gate man can sue for any reason. But the question is, are you legally correct in the court of law? That is what exempts you, sir and ma'am. Thank you very much. Just I should let you know this. Thank you.
Thank
Thank
you.
you very much, sir. Thank you, sir. Chief Ramigo, sir, you have the floor.
All right, thank you. I think Prof has actually said the major thing I wanted to say. I wanted to make it known to especially the person that commented on not telling the patient because of fear of that if the patient reacts badly or takes your information badly, it might also be because you've not gathered proficiency in breaking bad news. Okay, so because the truth is, every bad news that you break to a patient has the potential to cause them more grief. So you cannot say because of that, you no longer give them their information, okay? So whether the relative tells you or not to tell the patient something, the truth is that you must always break bad news every single day of your practice to your patients. And therefore, you must develop competence in breaking bad news, okay? So that you will find a way of handling that. Even the patient, even the relative that told you not to tell the patient, you should also know how to handle or field such situations, okay? Explaining explicitly to the patient that it is illegal not to allow, or I don't want to use the word illegal, but it is unethical for the person who you are treating not to be given information about their health status. It's only that person, especially if the person has no cognitive impairment, that has a right to say, doctor, please, for now, I don't want to know. And that's why you must always ask them, do you really want to know? What do you think? That's why we need to practice on how to give information to our patients and even their relatives when there is a need for that. Okay, so, but apart from that, I think the presenter did a very good job, okay, of discussing ethics. Okay, so please, as far as this patient has the cognitive awareness or is not cognitively impaired and has not told you that you do not want to get the information, you owe them as a duty, as an ethical principle to give them this information in a way that it will not harm them further. So you must also know how to pass the information across. Thank you.
Thank you, sir.
Thank you very much, sir. Thank you, sir.
Thank you,
Okay,
sir.
so Dr. Chris Ade said in the chat that when there are difficult or complex ethical dilemmas, you may also resort to the hospital ethical or institutional review board, if there is one, to also address this kind of situation. So thank you, Dr. Chris. So I'll hand over to our facilitator, Chris Ade.
Thank you, Dr. Simitokwe. Thank you. Thank you, Dr. Maduka, as always. did well. Thank you so much. All our teachers from Prof. Tito, Remigus, all Dr. Fatima Okopi, Dr. Dr. Success News in class today. We appreciate your presence. We do. Thank you, Chief Cookie. Thank you, everyone. Thank you, everyone. We appreciate your presence. Thank you. The two presenters, wonderful. Thank you. Then Dr. Temitope, thank you so much. The way you took over the class, I wish our government are like these ladies. So wonderful, very hardworking, very organized. Thank you so much, Dr. Temitope. We appreciate you. Thank you. So tomorrow is Thursday, so we'll continue tomorrow. Thank you so much. Have a wonderful day, everyone.
Thank you very much.
Bye.
Bye.